Hello all, welcome to yet another interesting session in biochemistry. This is Dr. Mathangi, Associate Professor of Biochemistry. Today's topic of discussion is about hemoglobin and its metabolic breakdown products, that is a bile pigment. While we are all familiar with the term hemoglobin and what it does to our system, we pretty much know about also about the lifespan of RBC. So the lifespan of RBC is 120 days on an average. So what happens suppose this 120 days tag? RBCs are taken to the reticuloendothelial system of the spleen and they are broken down completely. So here in this session we will see what happens to the hemoglobin part of RBC. Hemoglobin is a conjugate protein. It consists of heme and globin. Globin is a proteinaceous part and the heme is a non-proteinaceous part. Looking carefully into the structure of heme, it is made up of a metalloporphyrin ring, and in the center of the ring you have iron atom present in oxidation state of +2. This is very essential for the binding of oxygen and also for the transport of oxygen by the hemoglobin molecule. What happens to this hemoglobin molecule when the RBCs are destroyed? The hemoglobin molecule gets broken down into heme and globin. Globin is further broken down into amino acids, and these amino acids enter the amino acid pool and they are recycled by the cell. Coming to the heme part of it, heme is a metalloporphyrin ring. It's a bigger ring containing the iron atom in the middle. The iron atom will be reutilized by the cell. As we all know, iron is never excreted outside the body. Now what happens to the ring? The ring is opened up and then it is reduced to two types of pigments called as bile pigment, namely biliverdin and bilirubin. So please understand, bile pigments do not have any physiological or biochemical significance inside our body. Do not get confused with bile salts. Bile pigments are only for pigmentation. They pigment the urine and the feces, whereas bile salts help in emulsification of fat. Bile pigments come under hemoglobin metabolism and bile salts come under cholesterol metabolism. They are products derived from cholesterol. So coming back to hemoglobin metabolism, bile pigments are the end product of catabolism of heme, and they are of two types, biliverdin and bilirubin. Biliverdin will be green in color and biliverdin undergoes further reduction to form bilirubin, which will be yellowish orange in color. Both biliverdin and bilirubin are excreted through the bile, but the larger percentage will be bilirubin. These two molecules, being a long chain molecule, are insoluble in water, so they have to be appropriately bound to a protein so that they get excreted into the bile and they also get absorbed into the plasma. So this process of making these bile pigments bind with a protein is called as conjugation. So and this conjugation is done with the help of an enzyme called as UDP glucuronyl transferase. So when the bile pigment binds with glucuronic acid, it becomes soluble and it gets transported through the water medium which is present in plasma. Every time the conjugation may not be 100%, so that which is unconjugated will be bound with albumin and gets transported throughout. So coming to the excretion of the bile pigment, the bile pigment is mainly excreted through the enterohepatic circulation. It goes through the intestine. While some escape and get into the general circulation, excreted through the kidney. The other remain in the larger intestine. They get acted upon by the bacterial flora and they get further broken down. So the principal excretory form of the bile pigment that we see in urine is called as urobilin, which gives a straw yellow color to the urine. And the principal excretory form of the bile pigment which is found in feces is called as stercobilin, and it gives a characteristic color to the feces. Now moving on to the important aspect of this class, what are all the abnormalities associated with the bile pigment and what is the normal amount of bile pigment produced in the blood? Normally 1 milligram of bile pigment, be it bilirubin and biliverdin, either in conjugated or unconjugated form, is present in plasma, which is considered to be normal. The level above this is called as hyperbilirubinemia. Hyper means more. Bilirubin, we are talking about the pigment, and emia indicates its elevated level in blood. Hyperbilirubinemia. Hyperbilirubinemia is physiologically called as jaundice. While we are all familiar with the term jaundice, we normally associate jaundice with some disorder associated with the liver. So, jaundice by itself is not a disease, it is a symptom, something similar to fever, which indicates some abnormality associated with the liver. So, throughout this lecture, we will be discussing the different types of hyperbilirubinemia, which results in a clinical condition called as jaundice. So, hyperbilirubinemia broadly is classified into two types, acquired and congenital. Acquired is something which an individual gets during the course of his lifetime due to an infection or injury, and congenital is something which is inherited right from birth, mainly because of gene mutation, gene defect, which in turn affects the functioning of a protein involved in the metabolism of bile pigment. So, let us begin the series with acquired jaundice. So, the different types of acquired jaundice are prehepatic jaundice, hepatic jaundice and posthepatic jaundice. Prehepatic jaundice, as the name indicates, the liver is functioning normally, whereas the abnormality is before the pigment reaches the heme molecule reaches the liver. So, the common cause for prehepatic jaundice is increased hemolysis, where there is abnormal lysis of RBC and there is increased load of hemoglobin to be handled by the liver to be broken down to bile pigment. Under this condition, conjugation is also difficult and the excretion of the bile pigment is also difficult by the liver. The second type of acquired jaundice is hepatic jaundice. The most common cause for hepatic jaundice is viral hepatitis caused by virus. It could also be because of cirrhosis of the liver, certain drug intoxication, poisoning and tumors associated with the liver. The third type of acquired jaundice is post-hepatic jaundice, where the breakdown of hemoglobin is normal, the functioning of liver is normal. However, the excretion of the conjugated or the unconjugated bile pigment through the hepatic portal circulation is affected. The common cause for post-hepatic jaundice is gallstones associated with liver, with the gallbladder, or it could be because of tumor in the head of the pancreas, or it could be with a tumor associated with any other part post-hepatically. So, moving to the types of acquired jaundice, let us see the clinical presentation and how to diagnose acquired jaundice. So, let us discuss the characteristic biochemical features associated with the three types of acquired jaundice. So, in prehepatic or hemolytic jaundice, the type of bilirubin that is raised in plasma is unconjugated bilirubin. The type of bilirubin that is elevated in plasma in hepatic jaundice is unconjugated as well as conjugated bilirubin, and the type of a bilirubin that is elevated in post-hepatic jaundice is conjugated bilirubin. So, how to identify with a simple biochemical test about the type of jaundice? So, there is a single gold standard test to identify hyperbilirubinemia, and that is called as Vandenberg test. So, this test is normally done with a plasma sample. So, this is actually a two-phased reaction wherein we add a reagent called as a Ehrlich diazo reagent, and if the plasma sample produces an immediate reddish purple color, result is described as direct positive. Upon adding the reagent, if there is no color formation, then it is indirect. Upon adding the reagent and followed by that addition of alcohol, if the color develops and if the color deepens, then the result is recorded as a mixed type. Let us see the correlation of this test with the type of jaundice. As I told you, by adding the Ehrlich reagent, it is nothing but diastereosulfonilic acid. Immediately a purple color is produced, then the result is said to be direct. If the color is produced after the addition of alcohol, it is said to be indirect. If the sample produces a faint color and upon addition of alcohol the color deepens, then it is said to be mixed type of jaundice. So, let us understand the logic behind the Vandenberg test. So, first let us take condition 1, where upon adding the reagent you get a direct purple color. So, this shows that the bile pigment present is conjugated bilirubin, that is, it is conjugated with UDP glucuronic acid. So, by adding the diastereosulfonilic acid, it forms a bond and it gives a purple color. Coming to scenario 2, wherein by adding the reagent we do not get color, but upon adding alcohol and adding the reagent we get a purple color. So, why initially there was no color? This indicates the presence of unconjugated bilirubin in plasma. Kindly recollect that I told you when the bilirubin or the bile pigment is unconjugated, to enable its transportation, it will be bound with albumin. So, albumin is a bigger protein, it is bigger in size. So, when you add the sulfonilic acid reagent, the bile pigment may not react with it, and therefore you will not get a color instantaneously. However, by adding alcohol, you denature the albumin. As a result, now the bile pigments are free to react. They react now with the reagent and they give a purple color upon addition of alcohol. So, this indicates or this confirms the presence of unconjugated bilirubin. So, what is the biochemical explanation behind case 3 wherein initially a purple color develops, but after adding alcohol the color deepens. So, this indicates the presence of both conjugated and unconjugated bilirubin present in plasma, as in the case of hepatic jaundice. The unconjugated one takes time and it develops a color after the addition of alcohol, whereas the already conjugated bilirubin instantaneously reacts with the reagent and it gives a purple color. So, this explains the logic or the principle behind the deepening of the color in case of mixed jaundice. So, direct jaundice or the direct reaction or the direct fraction indicates the presence of conjugated bilirubin in larger amount in plasma. The indirect fraction indicates the presence of unconjugated bilirubin in the plasma, whereas the mixed one indicates the presence of both conjugated as well as unconjugated. So, how would this help in interpreting the result? As we all know, pre-hepatic jaundice is always associated with unconjugated bilirubin. So, you will get a late positive result after the addition of alcohol with respect to Vandenberg test. Hepatic jaundice is associated with unconjugated as well as conjugated bilirubin. So, you will get a mixed phase reaction with respect to Vandenberg test. And post-hepatic jaundice or obstructive jaundice will give a direct positive test with respect to Vandenberg reagent. So, with a single biochemical test, we will be able to distinguish the three types of acquired jaundice. Now, moving on to the interpretation of the test, we have to quantitatively estimate the amount of bilirubin present in plasma. As said already, the normal level of bilirubin in blood is 1 milligram per deciliter. Anything over 1 milligram per deciliter is reported as hyperbilirubinemia. If the level of bilirubin is between 1 to 2, the condition is described as latent jaundice, and if it is more than 2 milligram per deciliter, then it is called as jaundice or icterus. Let us also understand the normal level of conjugated and unconjugated bilirubin in plasma. The normal level of conjugated bilirubin in plasma is between 0.2 to 1 milligram per day, and unconjugated is 0.2 to 1 milligram per day, and conjugated is 0.1 to 0.4 milligram per deciliter. What are the other biochemical tests which will help us identify or distinguish between the three kinds of acquired jaundice, namely prehepatic, intrahepatic and posthepatic? The first one, as we discussed, about the presence of conjugated and unconjugated bilirubin. Secondly, there are certain enzymes which are of clinical significance in distinguishing between the three types of acquired jaundice. First enzyme which is diagnosed is AST. AST stands for aspartate transaminase and ALT stands for alanine transaminase. Both AST and ALT levels will be normal in case of prehepatic jaundice. It will be elevated in case of hepatic jaundice, and it will be again normal in case of posthepatic jaundice. Likewise, the most significant enzyme which helps in assessing liver health and jaundice is alkaline phosphatase or ALP. The ALP levels will be normal in prehepatic and hepatic jaundice, whereas it will be elevated in posthepatic jaundice. The most important urine diagnosis for jaundice is the qualitative analysis for urine bilirubin. Urine bilirubin will be present in case of hepatic jaundice and posthepatic jaundice, whereas it will be absent in prehepatic jaundice. And the urobilinogen in urine would be present in prehepatic as well as intrahepatic jaundice, and it will be absent in posthepatic jaundice. So, this we call it as differential diagnosis of jaundice using various biochemical parameters in addition to Vandenberg test. Moving to the second classification of jaundice, that is inherited jaundice, we will be seeing about the common presentation of inherited jaundice as a Gilbert syndrome, Crigler-Najjar syndrome, Dubin-Johnson syndrome and Rotard syndrome. And these 4 types of inherited jaundice will be discussed in this presentation. The first one being Crigler-Najjar syndrome. Crigler-Najjar syndrome occurs because of a defective UDP glucuronil transferase enzyme. Kindly recall that this enzyme is the key enzyme for the conjugation of bilirubin in liver. So what will be the consequence of this? In Crigler-Najjar syndrome, there will be increased amount of unconjugated bilirubin and the clinical findings would have profound jaundice, that is hyperbilirubinemia in blood. The second type of genetic disorder that we are going to see is Gilbert syndrome. Here, the enzyme UDP glucuronil transferase is very much present, but its activity is reduced. Therefore, again we will see unconjugated bilirubin high in blood, but the level would not be as high as Crigler-Najjar syndrome. So, the patient will present with mild jaundice, especially during illness or any hepatotoxicity. The third one is Dubin-Johnson syndrome. Here, there is abnormal transport of conjugated bilirubin into the biliary system because of the defect in the transport protein. So, there is no problem with conjugation. Here you have conjugated bilirubin. The conjugated bilirubin will be more in plasma because it is not getting into the biliary system for excretion. So, the clinical findings, patient will have moderate jaundice. Let us move on to physiological jaundice. So far whatever we have discussed as acquired and congenital. Congenital is inherited, the acquired jaundice were mostly pathological. Now let us move to the different types of physiological jaundice. As the name indicates, physiological jaundice is not something that has occurred because of a pathological event or some infection. It is a normal condition normally seen in neonates and in infants who are born preterm. So, why do these neonates or the infants who are born preterm have hyperbilirubinemia and what is the risk factor associated with it? First, let us see why hyperbilirubinemia develops in neonates or in preterm infants. So, this is because of lack of complete functioning of the liver and the enzyme UDP glucuronil transferase. Again, recall UDP glucuronil transferase is the key enzyme which helps in a conjugation of bilirubin. So, this enzyme is fully functional only when the gestation is complete. So, when an infant is born preterm or in some neonates, there is an increased chance of this enzyme being less functional or non-functional, resulting in hyperbilirubinemia, and the condition is called as neonatal jaundice. So, what is the risk associated with a neonatal jaundice? Neonatal jaundice is completely treatable. However, if the concentration of bilirubin becomes more than 20 mg per deciliter, it results in a condition called as kernicterus, where it causes irreversible damage to the brain. For the reason being, the bilirubin crosses the blood-brain barrier and it affects the myelin sheath surrounding the neuron, leading to irreversible mental retardation in children. Kernicterus does not occur in an adult. The reason being, the blood-brain barrier is well established in an adult. So, the complication of jaundice as in neonate and in preterm infant is much more for the risk of kernicterus. Another important type of physiological jaundice that we discuss in biochemistry is HTNB, that is hemolytic disease of the newborn. It is also called as erythroblastosis fetalis. Here, the risk of jaundice develops because of increased hemolysis in the fetal blood and the cause being RH incompatibility between the mother and the fetus. So, this condition is predominant in women who are RH negative and the child being RH positive. The RH antibodies that crosses the placenta reaches the mother and it triggers the production of RH antibody. So, this could trigger antigen-antibody interaction and clumping of RBCs in the fetal blood. It could even lead to the death of the fetus. So, RH incompatibility leading to jaundice is called as erythroblastosis fetalis. This may not be evident in the first pregnancy. For it takes the immune system of the mother to develop the antibody sometime. However, this will develop a serious consequences in subsequent pregnancies. That's all about jaundice and its types. and the condition associated with jaundice is hyperbilirubinemia, and hyperbilirubinemia mainly results because of either it could be acquired or it could be inherited. In case of acquired hyperbilirubinemia, the cause are classified into three categories: prehepatic, hepatic and posthepatic. And for the inherited type of hyperbilirubinemia, we have discussed the common symptoms which are due to inefficient conjugation of bilirubin. Please understand that the normal level of bilirubin in plasma is 1 milligram per deciliter. Anything more than 1 milligram per deciliter would be called as hyperbilirubinemia. Hyperbilirubinemia and jaundice are not synonymous. The word jaundice is used when the level of bilirubin in blood is more than 2 milligram per deciliter. Always remember, jaundice is a symptom and it is not a disease, and jaundice is characterized by hyperbilirubinemia. The underlying symptom could be anything prehepatic, hepatic or posthepatic. Accordingly, we classify acquired jaundice into prehepatic, hepatic and posthepatic. The cause and the biochemical changes we have discussed in detail. In addition to checking for the levels of bilirubin, there are also certain enzymes which are assayed to identify the extent of jaundice, and they are AST, aspartate transaminase, alanine transaminase, alkaline phosphatase. In addition, urine levels of urobilinogens are also measured. Moving on to inherited jaundice. Inherited jaundice or congenital jaundice occur mainly because of the defect in the enzyme UDP glucuronide transferase. The third category that we saw in today's session is physiological jaundice. We have seen two different conditions under physiological jaundice. One is neonatal jaundice, which occurs in preterm infants because of the lack of fully functional UDP glucuronide transferase enzyme. And the second type being HTNB, which occurs because of RH incompatibility between the mother and the fetus. So the key takeaways from this session would be: you should know what is hyperbilirubinemia. You should know that bile pigments are produced in liver. Names the two bile pigments, bilirubin and biliverdin. And bile pigments do not have any physiological or biochemical function inside the body other than giving color to the urine and the feces. You should be familiar with conjugation of the bile pigment to enable its transportation, and the key enzyme that is involved in conjugation, that is UDP glucuronide transferase. Understand the difference between conjugated and the unconjugated bilirubin. Unconjugated means the bilirubin or the biliverdin pigment is bound to the protein albumin. Learn the significance of Vandenberg test in identifying direct, indirect and mixed reaction, which in turn helps to classify jaundice as hepatic, prehepatic and posthepatic. Also, we discussed the normal levels of bilirubin and the abnormal levels of bilirubin, and understand that kernicterus is the risk associated with neonatal jaundice. Thank you for your listening. If you have any queries, please write to us. We will be more than happy to help you. Thank you.